This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters, bones and joints provide support for our bodies, so when they fail, it can be debilitating and depressing.
Turning my head one way or the other would hurt.
How this woman refused to accept age as an excuse and found relief.
I was not ready for walkers and all that stuff, and I shouldn't have been.
Plus, your questions answered live by our panel of experts. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
Good evening, I'm Teresa Lukens, and welcome to Health Matters. Bone and joint pain can strike in nearly every area of the body. Tonight we're going to talk about symptoms and treatments, both surgical and non-surgical. And most importantly, we're going to give you some things that you can do to guard against bone and joint issues. Our panel of experts has you covered from head to toe. Dr. Chad Harbour is a board-certified orthopedic trauma surgeon and hip replacement specialist for Providence Orthopedics. He is the orthopedic trauma director for Sacred Heart and the orthopedic department lead physician. He specializes in orthopedic trauma and hip and knee replacements. Dr. Trevor Whiting is a podiatrist with Multicare Rockwood Clinic. He works out of the North Point and Deer Park offices and specializes in foot and ankle pathologies, including acute fractures and other injuries. Dr. Kelly Pearson is a chiropractic physician who owns a multidisciplinary clinic with her husband in the Spokane Valley and has been in practice for over 35 years. She specializes in finding the right treatments for patients. Dr. Kelly has been the team chiropractor for the Gonzaga Bulldogs basketball teams, as well as all of the other sports teams at GU. And finally, Dr. Ben Howie is a sports medicine physician for Providence Orthopedics and Sports Medicine. He specializes in non-operative care of athletes and patients that are seeking to live more active lifestyles. Much of his practice involves the use of ultrasound-guided injections to treat common multiskeletal issues. And I want to welcome all of you for being here tonight. It's a very broad topic. We're going to try to get as much in as we possibly can tonight. And we also welcome you to join the conversation with your questions by phone or email. And a reminder, too, that we are streaming tonight's program on the KSPS Facebook page. So let's talk a little bit more about all of your areas of expertise. And Dr. Whiting, we'll start with you.
I'm a podiatrist, as you mentioned, dealing strictly with the foot and ankle. We deal with things from the bones and joints of the ankle and the foot down all the way to the toenails. So anything from the nerves to the structure to the skin and everything. So.
And we're going to get to some of those specifics tonight too as well. And Dr. Kelly Pearson, talk more about your area of expertise.
Well, it's interesting. I love working with young people and certainly the athletes, but as I get older, it's a funny thing how all my patients are getting older. And maybe 4 or 5 years ago, I got very committed to letting people know that they don't have to age in the way we think we're supposed to age. And really, there's a lot we can do to be able to squat, bend, lift, twist, and reach. But we have to work at that just a little bit. And so that's one of my passions is lecturing to seniors to get them to not age poorly. And I'm not talking about wrinkles. I'm talking about functional mobility, living in your body, and you wake up feeling good.
Mm-hmm. Being able to do more.
Yes.
And this group, this aging group of people, I use that term relatively because I fall into that group, wants to do more. They're more athletic. They're out there doing more things.
Yes.
Yeah, so we're going to get into that as well. Dr. Howie.
So, like you mentioned, I get the pleasure of helping to keep people moving, and when they are at the point where they don't need surgery yet, and we explore all the non-operative options to get them better. And I see athletes and just anybody that needs to keep moving. And so that could look different for everybody. Some people, it could be a high-level athlete, or some people it could mean getting up and going to the dinner table. But it's a pleasure. It's fun because I have a lot of motivated people, because patients want to move. They want their body to function correctly. And often we're just harnessing the body's natural ability to even heal itself by doing some basic things, and then when needed, to intervene. And like you mentioned, I use ultrasound a lot. Yeah. And so if people need injections that need guidance or any procedures, I really enjoy doing that to help get people moving again.
Okay. And our surgical guy.
So orthopedics really is about function, and a lot of what we do really is to restore that function. And whether it's with motion, with putting people back together again. Half my practice is orthopedic trauma. When somebody breaks something, we usually will help them out. Not everything needs surgery, but there's a lot of surgery involved. The other half of my practice really comes down to hip and knee replacements, and that again goes back to function and motion. And of course, not everybody needs a surgery right out of the gates, but ultimately there's a lot of people that would benefit from hip and knee replacement with their arthritis.
Yeah, we're going to get more into treatments, but so many advancements in the area of hip and knee replacement that we can talk about tonight, and getting people back on their feet a lot quicker. How do we know, because we're talking about bones and joints tonight, but how do we know when pain is associated with a bone or a joint, not a muscle, not something else going on in the body? I guess if I start to feel some sort of pain issue, what's my first course of action? Dr. Howie?
So the first question is, how do we know?
Yeah.
Usually it's going to be location of pain. So localizing where it hurts, often that can give us clues to say the joint is possibly a culprit. And then just thinking about imaging, x-rays are the most common to say that joint could be involved. And but really it's the history, hearing what a patient says, and the physical exam that leads us towards suspecting a joint. And then it kind of depends what's going on as far as the treatment, because it can look all sorts of different ways. One could be right to surgery. One could be, let's just wait it out. So it kind of depends on what the issue is.
Mm-hmm. Is the first course then to see your general practitioner? Kelly?
I think it depends upon the person's bias, what they grew up with, what they've known, what they've done. And so I think that the functional exam of the body really helps to determine, is it muscle, is it joint? But truthfully, I never see them separate. I see a spectrum. Slowly muscle challenges become more of a problem, and joint restriction becomes more of a problem. Then osteoarthritis kicks in, and now it's all joint that's limiting, with now atrophied muscle. So it's, where in the spectrum are we pointing, and where can we intercede to make the biggest difference functionally? And I like to hope that, you and I might be trying to help them out earlier on, but I'm thankful that there's surgeons who can help them out when it is too late to make change, and they need that joint replaced. So we have a really great spectrum of providers in Spokane in that regard, that's for sure.
Mm-hmm. And often you will use that team approach when you're treating a patient.
We do. I refer patients to Ben on a regular basis for injections and other non-surgical treatments to help them with their pain and to help keep them moving in more of a pain-free manner. So we usually try to exhaust all non-operative treatment before we come to the surgeon and start talking replacement.
Mm-hmm. What are some of the natural things we can expect with aging with bones and joints? The things are going to break down as a natural part of the aging process, but there are some things we can start to hold off, as you mentioned, Dr. Pearson, and take control, I guess. But what are some of the things that we're going to start to see with the aging process? And let's start with the ankles and the feet.
Arthritis, obviously, is one of those. Get a lot of patients with arthritis. But also, leading up to that, there's soft tissue injuries. Plantar fasciitis is a really common.
Explain what that is.
That's inflammation of a ligament in the bottom of the foot that attaches to the heel. Most often, the pain is at the bottom of the heel. But it can be in the mid-arch as well. But that's something else that we see a lot of, that not necessarily aging, I guess. We get that of all ages, but it is probably more common in the older population.
Mm-hmm. Are there actual things that you can do to hold off, like a plantar fasciitis or bunions or any of those issues that you'll often see?
There's a lot of conservative treatment that people try. Thank goodness we have those. And that is probably the most common thing that I see in clinic is plantar fasciitis. It's one of the most common pathologies, and rarely do I have to take those to surgery. So the conservative treatments are typically stretching, and it's stretching your calf muscle.
You don't think about that with your feet, yeah.
You don't, but it's actually stretching your calf muscle and your Achilles tendon is what I found to be the most effective conservative treatment for the foot issue, because it's directly connected to that ligament and to the strain that goes on it.
That's something you could do in front of the television.
Yeah, sure can.
All right.
Sure can.
I know the doctors are giving me the side eye on that comment. And Kelly, you actually have a class where you work with aging patients to get them up and moving.
Yes, and so I do think that we see more and more arthritis, and it's because we're more and more inactive. And I think you can look at a body and see it move and almost historically figure out where they got hurt, around what age. So I'll have a baseball player that slides on his right hip all the time. His left hip, he's 38 now, his left hip is fine, his right hip is shot and he needs a replacement. He was a big athlete, did not like massage, did not like manipulation, did not like self-care, just play the game. So I think arthritis is really, it's a storybook of how we've been living our life, and if we've been getting proper treatment for our owies, we have to get care when we get hurt. And certainly when you break something, you don't have an option, but so often people just take ibuprofen or Advil, and before you know it, now you have asymmetrical mobility in the joint, you've got stiff joint, the body becomes really tight. It would respond to manipulation early on, most definitely, but a lot of people wait years and years and years, and now almost fusion occurs, and some autofusion occurs in some joints. So I really think that you can have really healthy 90-year-old people who can bend, lift, twist, do push-ups, and sit with their legs out. And why? Because I see them. Why them and not others? It's really a bias about how we care for ourselves, or what resources we have, or how we eat and how we stretch. If we believe in stretching, do we drink water? Are we an aspartame addict with pop? All those things leach calcium from the bone, and bone is living tissue. It responds to good things and also responds to bad things.
And you probably see the same thing as well.
Yeah, very much so. And just, I think, in getting back to it, that the lack of movement is often a big thing that leads to these things that end up being, I like to think of it as victim and culprit. So the victim is what somebody comes in and says, I have knee pain. But often it's from something else, something higher up the chain, hips, even posture, things like that often are way far away from where the issue is. But usually it's something that over time, with lack of activity, with even positioning while somebody is at work, things like that lead to a certain part being overused or overstressed more than it should. And then, so now it's working backwards through that to say, we can deal with this, but let's take care of what led to it so that it doesn't happen again, and you have more longevity so that doesn't keep happening. Otherwise, it's a cycle of treating and something else breaking.
And then they end up possibly needing surgery and those replacements. And that can be, as we mentioned, years worth of overuse or not treating those injuries properly.
It definitely plays into it. I mean, I think what we see a lot more, there's multiple types of arthritis, so to categorize it as one type of arthritis, I think would be to undersell it. The big thing is, you've got, the most common is osteoarthritis, and that's, we've always kind of equated that as the wear and tear arthritis. We're seeing a huge rate of increased post-traumatic arthritis with all of the club sports and all of the year-round playing that a lot of kids are doing these days. The time they hit their late 20s, early 30s, we're probably doing more hip and knee replacements now in a younger population than we ever did. There's autoimmune arthritis, the rheumatoids, the psoriatics. So, there's a lot of reasons people's joints wear out on them.
Okay, we have our first phone call tonight, and I've kept Deborah waiting, so we want to get to her. Hi, Deborah from Mallow, Washington. Good evening.
Good evening. I'm an old ballet dancer. I'm 67. I danced from the age of 10 to 43. My ankles are bad now. I've already had hip replacement, but my ankles are so bad, and I guess I'm thinking, 10 to 20 years ago that nobody could do anything for my ankles.
Yeah. So is your question what can be done for your ankles then? Am I understanding that correctly?
Yes.
You know, there's a lot of things that could go wrong with you being a ballet dancer. You know, really, ballet is a tough sport, and you're hard on your feet and your ankles, and you do a lot to that. I'm sure you guys find that in your specialties too. It depends on where your pain is and when that pain is affecting you the most. But really, it may be good to go in and have that looked at just to and have some hands on that ankle. Is it both ankles or just one of them?
Generally, it really gets bad later in the afternoon, and it's sort of they swell and sort of in the front of the ankle, but I also have pain on the sides.
Okay, on both sides too.
Yeah.
What have you done for it so far? What have you tried to treat that?
Well, I swim and I do water isometrics, and I exercise and I stretch.
Yeah.
And I get massage.
Do those seem to help pretty well?
They help some.
Okay.
I know that movement and keeping moving is so important, and so I'm very good about that.
Yeah, I think that's probably the best thing you can do at this point without being able to look at you and examine you. Keep things moving, but if it's hurting a lot, then stop. But
and see a doctor.
And come in and see us. Yeah.
Yeah, because it sounds like it might be a model patient. She's doing everything she can personally do without something surgical or something that you can provide for.
Yeah.
Yeah.
Can
Kelly?
I just add one thing there? So one of the things, there are chiropractors and osteopaths that specialize in extremity manipulation, and we do a fair amount of manipulating the multiple joints in the foot. The subtalar joint and the mortise joint, all of these don't make a lot of sense. But you can do some very gentle opening of those joints and mitigate a lot of pain, increase mobility, so they got more dorsiflexion, and they're doing better weight bearing, and they're moving, and their gait isn't so pounding. So finding somebody that likes to adjust extremities can be incredibly helpful, particularly when they're working with a physician and everybody feels comfortable working together as that village. And I see, working with Gonzaga, I'm adjusting feet every day.
Yeah, I bet you are. Yeah. Especially for those top athletes.
Yeah.
We have an email from Cheryl who says, how effective are joint supplements? Should a person be taking them with joint issues, particularly knee issues?
That's a great question. We get this all the time in my clinic. Probably the most common one is the chondroitin sulfate glucosamine. We've looked at that a lot in the U.S. literature, and we have not been able to see the effectiveness of that scientifically like they have in a couple of European studies. And they had very high dose pharmaceutical-grade chondroitin sulfate, and the Europeans in a couple of studies found some benefit with that. But again, some of the U.S. studies, we've done a lot of them, haven't come out with the same conclusion. So the reality is this, it's a very low side effect, or really no side effect with the chondroitin sulfate glucosamine. I've got patients that swear by it, and so I don't think you're doing any harm by trying it. I'd try it for a month is what I usually will tell people, and if they notice a difference, great. If they don't, I probably wouldn't keep spending their money.
What does it do?
It's supposed to help with the inflammation in the joints, and that's the biggest thing that I know of.
It provides some of the primary building blocks for cartilage tissue, and I think that's where the rub happens. Is it being absorbed or not? But I tell my patients all the time, my 14-year-old dog doesn't understand the placebo effect, but when I give him glucosamine, he trotted up the stairs. And like you, I do see a lot of patients that get a lot of improvement from that. And I think it's kind of like how pathologic are they? Are they just a little arthritic or severely arthritic? Because I think when you throw something that benign at it, you're not going to see a lot of change in somebody with severe arthritis, but you will in the early stage. So like you say, why not try it? It doesn't have a side effect. Unless you're allergic to shellfish, there can be some trouble with that.
Any other supplements that you recommend or that you hear that patients are taking? And
there's a lot of things that people are taking, and so I guess that would be my big thing, is to warn patients to know that everything that they see on a package is not true, and is usually not evaluated by anybody that's actually studying whether it works or not. And so just to be careful, I would really encourage people, start with the basics. Even when we think about things like even weight loss. So if you lose 1 pound, we find that for every extra pound of weight you have, it's 4 times that amount of pressure on a joint like the knee. And so thinking about, oh, what if I just lost 1 pound or 5 pounds? That could actually do worlds better, and it's actually proven to help for things like arthritis or other bone and joint issues. And so we live in such a society that's easily flashy things are popular and sell. And it's often
we want a quick fix.
It's the simple, boring things that actually work, you know. And so I just encourage people to always step back and say, really, what evidence does this have, and are there some more basic things that I can spend my time and money on that might be more effective?
Okay. I want to talk more about this team approach. So whether your pain is mild or severe or sudden or even long-lasting, finding the right treatment is key to finding relief. The answer for the woman that you're about to meet was a team approach to her overall health.
I am a happiness coach.
Leslie Vallely doesn't mind telling you that she's nearly 68 years old, and she believes you can be happy no matter what your age.
Happiness is not the exclusion of any emotions. It's actually the ability to include them all.
So now I train people in brain science and meditation and those kind of things so that happiness follows them.
But a little over a year ago, she was not in a happy place, suffering from vertigo and chronic neck pain. One doctor visit led to 2 more referrals, but she wasn't getting any better.
Doctor said it was part of growing old. Went to a physical therapist, like I said, to give me some exercises to increase my management of the balance issues, not to undo the balance issues.
Drive back and come up. Perfect.
To be told that her neck pain, vertigo, and the nausea that came from them were symptoms of age was depressing for this normally active grandmother.
I'd sort of bought the story that I was just getting old, and it was sad for me.
Rather than give in, Leslie went to see a chiropractor who had helped her with other issues. The Pearson and Wary Clinic offers a collaborative program in which a patient sees 4 specialists in one visit.
That would involve working with a chiropractor for 15 minutes, working with a movement specialist for 15 minutes, working with a nutrition coach for 15 minutes, and then having a 15-minute specific massage based on the area you've come in for concern.
It didn't take long to determine the cause of Leslie's vertigo, and it wasn't old age.
It's digestive vertigo, and the spine has a lot to do with digestion. I don't know how many people know that, but the spine tells everything what to do. So, long story short, I don't have vertigo anymore.
So basically what I'm just having you do is bring your rib cage down. You feel the
chronic neck pain is gone too. This happiness coach has her own happiness back. And with help from her nutritionist and her movement coach, Leslie feels empowered in maintaining her own health.
This is what you can't really measure, is how you feel cared for. Like there was a team of people who believed in me.
So how are you feeling after that?
Relaxed and open.
Wonderful. That's exactly what you want to feel, that nice opening.
And that, I think, made a huge difference.
Good.
Yeah.
Good.
I was so impressed with Leslie. I really got a kick out of her. And a couple of things I took away from that was her attitude. First of all, she, after, initially accepting, well, I'm just getting old, she said, no, I'm not going to accept that. And she found a way, and through your clinic, to relieve that neck pain and the vertigo that came with it. Talk about this program that you have set up where we see you see a different professional for 15 minutes each.
So for these many years I've been in practice, I think I've been frustrated about sometimes we leapfrog into the sexy, the expensive approaches sometimes because you want the best of the best, but we forget the basics, like you said, Dr. Ben. if you have a plant that's dying, you're going to water it. You're going to give it some fertilizer, put it in some sun, dig up its little roots, give it some space, say something nice to it, right? You don't go to the leaf graft first or look under for a bug and then take it for a biopsy. So the body's the same way. We have to water it and we have to move it, whether it's the joints that are restricted, the muscles are restricted. We got to teach it how to bend. We forget how to bend. We have to teach it to know that water is a painkiller and that pop is not, and gluten may be for some not so good, and what about fruits and vegetables? And so when you get, the literature says this, when you get a couple of those things all at the same time, people heal faster. So I just say, let's do the basics first, and if that fails, or in the interim you realize, no, this is a surgical case, I'm sorry, this is something we can't help here, which happens for sure. But let's at least cover the basics. And if you fail there, let's go for something that is more invasive or more expensive so that we can empower people. And that really is what it's predicated on. And I'm excited that it started, and I've been thinking about this for years and years. And I'm having a ball because I know when I see the patient, they're going to get exactly what they need that day instead of me going, hey, would you talk to my nutritionist because I noticed you're probably a little inflamed. Now it just happens and I don't have to cajole.
Well, that connection to our overall health, it's not just your knee or your hip or your foot. It could be the overall health and even the mental piece. I mean, that was wearing her down when somebody said, you're just getting old. She just refused to accept it. So it's a neat program. You had to do some convincing in your own office, though. Your own husband was a tough...
Of course. I'm married to this wonderful man, but I've had some crazy ideas. This one actually is a good one.
Falls can be an issue as well, and taking a fall, breaking a hip, or injuring a knee, but doing those exercises to make sure that you can have your balance and that you're preventing that.
Yeah, super important, and like you said, so the things that can help are balance, and so that actually, in the way that we get good at balance is by practicing it, right? So getting up and moving and doing that in a controlled fashion, so you don't fall where you're doing that, but balance and even formalized physical therapy or home exercise programs are a great way, along with other aids as far as things that can help you walk or things of that sort, but super effective in preventing falls. And then you think about, as we go back to the basics, when I fall, what happens, right? If my bones are, I haven't eaten well for a long time, and my calcium, vitamin D intake has been low for 40 years, they're probably not going to be as dense as they should be, and they're going to crack more easily. And so that's thinking, down the road. That's a huge thing to say. Bone health in general, what do we do to make that better so that when you do fall, it doesn't fracture? And then they end up, Dr. Harbor's fixing them.
Do we naturally lose bone as we age?
We sure do, Teresa. Yeah. And I mean, the other thing, too, you can't discount the fact that some people definitely are more predisposed to osteoporosis. And we see it at higher rate in women. Post-menopause, you lose the protective effects of estrogen. Rates of osteoporosis go up. So 100% agree with the balance and the muscle strengthening. And I mean, diet and exercise and all of these things absolutely compound for the advantage and benefit of people in the long run. But there are some things you can't control, and family genetics, sometimes you can't outrun them.
A bone density test, do you recommend?
I do. So we get something called a DEXA scan, and it looks at a couple of different spots in the body for the bone density, and then there's actually a gauge there that lets us know where you fall on the averages. And if your bones are osteopenic, where they're thinned out but not diseased like osteoporosis, then there's some options. There's the vitamin D, which is not a magic bullet, but it definitely helps your gut absorb calcium. It's something that does help. And there's other things that you can do. If you get into osteoporosis, then you really need to start talking with your physician about some of the treatments for that. Bisphosphonates are a whole line of medications that help our bone density increase. But they have some drawbacks, and there's some definite side effects with them. So it's one of those things that you definitely have to have a conversation and really weigh out where you're at.
All right, we have an email coming in from Ivar who says, and this is a topic that's somewhat controversial. We actually discussed it a little before the program tonight, but he wants to know what we think or what the panel thinks of the usage of stem cells. Who would like to tackle that?
I guess I'll start. So, first off, Ivor, that you're going to, everybody out there, you're going to see things about stem cells, about PRP, which is platelet-rich plasma, about regenerative medicine, because it is something that's in the news, and professional athletes are doing it, and you're hearing about it. And so the first thing I would say to anybody out there is to use caution, because it is something that's not regulated well, and one person's or one place's stem cells are not the same as the other places, and it's really not regulated. So we don't know what you're getting when you go there. And often these are kind of high pressure sales type situations, and I would be wary of anything like that as a patient. So,
where are we seeing them being used?
Everywhere.
And for what types of treatments?
Everything.
Everything.
Really?
Yes.
So they're claiming it's a cure-all.
Well, I think it's a new industry, and there's not enough time passed or not enough definitive science. I mean, I've seen patients, elderly people, lose thousands and thousands of dollars for conditions that I knew it would not be beneficial. You have a bent knee, what we call genu valgus, and they said this stem cell would correct that. Well, my goodness, the only thing that could correct that would be this doc. But the point is, it breaks my heart to see the greed overcome. And it's that way with every new cool thing in medicine. We just have to give it time. I believe there's going to be some really useful utility for it. So we can't throw the baby out with the bathwater. It's exciting on some level, but I don't think we're ready to declare.
And more research needs to be done?
Absolutely. There's some very limited research with people's own blood that they take. They spin down to harvest their own stem cells, and then most common that I see in patients that I've interacted with is to get their knees injected. But when you look at the science behind it, and I've read a couple of the articles on it, it's not good science. And right now when we weigh stem cells versus a very common injectable is something called hyaluronic acid, but it's like a joint lubricant. There wasn't a clear win with the stem cell. And again, this is people's own stem cells. Then there's embryonic stem cells. There's umbilical stem cells. There's different parts of the body they can harvest them, and by no means am I an expert on that. But like Dr. Howie's saying, you don't have quality control out there right now. So there's a lot of science lacking with them, and I absolutely would tell people, please beware with going and getting your knee or your hip or whatever part of your body injected with stem cells.
Yeah, with the amount of money being spent, that's very scary. We have a phone call from Buford in Leavenworth. Hi, Buford.
Hi.
You have a question?
I really appreciate you covering this. My wife and I both are in our mid-70s, and we both have osteoarthritis. I've got it in the knee. I've had it for the last 5 years. It was moderate 4 years ago. It's been diagnosed recently with severe, and I'm eligible for a knee replacement. But I have found, and I'm surprised that your doctors haven't been discussing this, I have found that I can control it if I walk at least a couple miles a day, keep my weight down, and I do yoga. So I'm wondering, I wonder if, we all are looking for some magic pill, whether it's stem cell or glucosin or whatever, when some common exercises could alleviate pain.
I think you're spot on, Buford.
Well, I feel bad that we haven't been clear about that, Buford, because I think we all would agree that the movement is number one, and to maintain the movement that God gave you to be able to bend, flex, twist, reach up, and squat and pop up. Those things have to be practiced, like balance has to be practiced, and walking every day, and good food, more fruits and vegetables, maybe some turmeric, throw some vitamin C in there. All of that makes a huge difference, and certainly I think each one of these docs practices that way first. And maybe we don't speak enough about it, because people, Buford, I hate to say this, but patients want answers right now, some cool thing to be done. You are the perfect patient. I wish you would come to Spokane.
It's so important to say, okay, so exercise, so activity and strengthening of muscles actually is proven to help arthritis and to increase function in somebody with arthritis, decrease pain. And so that's huge. And the other thing is that often people get x-rays An x-ray only gives us a little piece of information. It can show that somebody has severe arthritis and they don't have a symptom. Their knee feels totally fine. And then you get somebody with just barely little arthritis and they can't even move it. So I would tell people to don't take that image for what it is and to say it's still arthritis.
That can get in your head too.
Yeah, you say, look, it's bone on bone. I can't do a thing. But some people can. And so I would ask people to look past that and to say, how can I, in my circumstance, get more active and do these little things that can help, just like you said, Buford, which is awesome.
Yeah.
Keep it up.
Yeah. We're not treating x-rays.
Yeah, exactly. Well, how do you push past that? If you are having pain, though, how do you push past that to do those exercises to get to the point where you're feeling better? That's got to be a stumbling block for a lot of patients.
It is, and arthritis is really the natural course is exacerbation or remission. So you'll have times where people have flare-ups, and so there are times that we will inject and do other things to try to get them through that flare-up. I mean, even if they have moderate arthritis on the x-rays and they haven't tried any non-operative treatments, I mean, that's the first line of treatment. You have to try the non-operative routes. I've had patients go several more years before they come back and want their joint replaced. And for me, that's a win. I mean, mechanical parts fail eventually. I mean, they have a finite life. Materials are getting better, things are doing better, but they still eventually will wear out.
And you have some real challenges with this because you're telling people to get up and move, and they've got foot or ankle issues, making it even more challenging.
Yeah, so a lot of times with arthritis in the foot, it's a little different than the larger joints. We actually, if it hurts when they're moving, we try to limit the motion with an orthotic or some type of supportive device. And if that fails, then we move on to, and we can do that with injections like you were talking about, but then we can move on to maybe some surgical options.
And that's where I think it's important to say, okay, if you have arthritis and you exercise and it hurts, maybe you need to step back. Maybe you need a muscle massaged. Maybe you need a joint manipulated. Maybe you need to learn how to heel toe so that you can start to control that pain, and then you're more incentivized to exercise. Just because, oh Lord, if you start to exercise and it hurts, so I'm not doing that again. But that's a real thing for us. And recognize that those basics of movement of joints, lengthening of muscles, and proper movement patterns, you've got it. We have to expose those people to these things before we jump to, well, let's do an MRI, because like you're right, you can't unsee a crappy MRI. Yet 60% of us are walking around there with herniated discs and no pain at all. So I'm with you. We don't treat x-rays, but sometimes they're critical. We must have that imaging, and there's the art of practicing medicine.
Well, it helps for counseling too. When you see a certain degree of arthritis, I mean, it leads the conversation in a certain direction. And you know, we even when we're looking at joint replacement surgery, I mean, a big thing that we're starting to talk about in the orthopedic world is something called prehab, and really getting the patients in to get them reconditioned, to get them stronger, to get them to a point where they're, what I tell my patients a lot of time, to get you back in fighting shape. If you go into a joint replacement surgery, hip or knee replacement, it's very taxing on the body. If you go into that surgery deconditioned and already in a state that you're not moving well, you're not doing well, I'm going to tell you right now, it's a lot harder to recover from that surgery.
Talk about some of the specific exercise. We use exercise, but Buford was walking and doing yoga. I assume those are good options, but what about weight-bearing exercises or resistance exercises, and why do they work?
I have a couple thoughts. Do you want to go first?
Yeah, so start simple, and especially if you're in a lot of pain, start low impact. So even things like biking, swimming, walking on flat, softer surfaces rather than big steep hills. Start simple and then slowly increase over time. But things that are actually weight bearing, at least for bone health, are actually good because it gives your bones signals to keep regrowing and staying dense like they should. And if they're not getting those signals, then the bone density is going to go down much more quickly. So weight-bearing activities are okay. But just to say, use your symptoms as a guide. So if something is hurting, step back and say, okay, maybe we'll try something a little different. But walking's fantastic. Biking, some of the basics to start with. And then strengthening, often an area where people are very weak is the hips and the core. And that's a great place to start with some basic kind of hip exercises and core rather than just go into the area that hurts.
And if you're completely lost as where to even begin, seeing a trainer or a professional, somebody that can kind of lead you through that so that you're not doing too much all at once or injuring yourself further. I would assume that's a good place to start.
Absolutely. I send quite a few of my what I'll call them pre-joint replacement patients to a couple of sessions of physical therapy. And really what I'll tell them is just, we're looking at 2 to maybe 4 sessions over the course of a month, month and a half to really have that therapist show you different activities, get you started on an exercise program, modify things. If you're having trouble with something, if you're trying to do squats and you can't do it, well, we need to find something that you can do that still accomplishes the same goal with the strengthening. And so there's a lot of professionals out there that are very good at what they do. We're fortunate we have a lot of therapists in town that do a great job with this. And so, again, it doesn't mean therapy needs to be 3 days a week for the next 6 weeks. It really, you can modify that.
Okay. I appreciate the prehab you guys are doing, and it seems like every day a new gym pops up, and these gyms are not just to lose weight and get stronger, but I send some of my patients to one gym in particular where he will not let this patient get hurt. He's going to get him stronger but never hurting. So they're being run by athletic trainers and things like that. So you're seeing this because of the baby boomer, I think, elevation. You're seeing a lot of places people can go to get stronger, and it's critical. And there's certain muscles in the body that just get weak. On our mid-back and our butt, gluteals, excuse me. Those
Some
get,
core
those
exercises
get weak,
might be in
and
order.
we have to strengthen those.
Okay. We've had Mary holding on from Spokane. Hi, Mary, and thank you for holding.
Okay.
Do you have a question?
Yes, I'm calling in regards to the hand pain that my husband has been experiencing. He is 82, and lately he has been having some real debilitating pain in his hands, and we would like to have you someone address diagnosis and possible treatment for whatever could help him, because he can't sometimes even want to turn a doorknob, let alone a medicine cap. And not quite sure if this is just arthritis or if there's other issues involved.
So, Mary, correct? First, I'd recommend go see your doctor and have that evaluated. Find out where the pain is. Consider getting some X-rays, because if it is arthritis, then you can go down that path. And there's a lot of really good things to do to actually help with arthritis of the fingers and hands. And so that'd be kind of where I would start. As far as the hand pain.
In occupational therapy, some of them, that's all they do is hand therapy. He may have carpal tunnel syndrome, and he just doesn't know to diagnose it. So amazing things can be done for this condition. I think you're absolutely right. She needs to get in the hands of her physician and let him direct to get to the specialist she needs to, after some x-rays probably.
Okay, thank you, Mary. I want to talk about bunions. May or may not be a personal question. What are they, and how do you treat them? I do have bunions. Truth be told.
A lot of people have bunions.
Thanks
you're not
to
alone.
both my grandmothers.
Yeah. and that is usually something genetic.
Yeah.
My patients always ask me, where did I do something wrong? Did I injure this? But it's usually when that big toe drifts over towards the little toe, and the first metatarsal starts to drift towards the other foot.
Is it bone?
It's your normal bone. Often, sometimes you get some bony growth around there, but it's the normal bone that is changing alignment. And it can be caused from a whole lot of different things, genetics being probably the most common one. I usually ask my patients, is it your mom or your grandma or grandma or grandpa or someone that has this? But that's what it is. It can be very painful. Sometimes the more painful bunion is not the one that looks the worst. It's okay.
Yep.
and so we obviously treat the one that is most symptomatic.
And how do you treat them?
We start with just supportive, trying to realign the foot and getting a good orthotic in your shoe, something to hold the arch up in your foot to hopefully align everything where it needs to be. Sometimes there's arthritis associated with that, and we have to address both issues at the same time. But we can try steroid shots as well. They're not going to fix it. They might fix, as you were saying earlier, the flare-up of the symptoms, but it's not going to change the alignment of the foot.
And that's where surgery would have to come in?
It is, yeah. But of course, there's more conservative treatment. We like to try to get you in wide shoes so that you don't wear shoes that are pushing on that bump.
There go my cute heels.
a lot of times that's unfortunate. That does happen. But a nice accommodative shoe that's not putting pressure on that. Sometimes it's just the movement of the joint that hurts, and there are different treatments for that too.
Now, if you don't have a lot of pain, can you just go on with them?
Yeah.
Yeah?
Yep, absolutely. If you're not hurting a lot, keep living your life. Stay active, like we've been talking about. Stay moving, and stay on your feet.
I think the physical therapy department would agree with this as well. If you get early on signs when your toe's like, what's going on there? You notice it and don't ignore it. You can actually build strength in the bottom of the foot and stop it. But it's hard to do that once it's gotten to the end zone. So again, where do we start paying attention to our symptoms? And we say to ourselves, oh, that's not much, until the one day it hurts. And then all of a sudden it's like, doggone it. Now what, 25 years in the making, the bunion is there. Yeah. And you may have to do surgery if it's really horrible pain. But again, whatever you can do to get stronger there, get some foot manipulation, we see that helping. People just don't want to give up too soon, I think, is the point.
We have another call from another Mary here in Spokane. Hi, Mary.
Hello.
And you have a question?
Yes. Would you ask your team to discuss the ointment that is made from the hemp plant, and the ointment contains CBD? Thank you.
Good. Thank you, Mary. Hot topic as well. Dr. Harper.
So Mary, I wish I could give you some good scientific basis to why CBD oil works for some people. I can't. I have not read enough about it. What I will tell you is I have a lot of patients that come in and are using it. And I think it's like really a lot of the ointments that are out there, the Asper creams, the Bengays, there's a lot of different things for different people that end up working for them. And so what I will say is this, I don't see a big downside personally for trying it. If you're getting benefit from it, great, but I can't give you great science to support it.
I would agree. I see a lot of the patients using it. As long as it's less than 0.3 milligrams THC, there's no negative effect in terms of having an influence. But the CBD, I think that's another area that there's a lot of research that needs to be done, but there doesn't appear to be any harm. And I've yet to find a patient who tried it who said it didn't help. I did have one patient who had a negative cognitive effect, and I kind of questioned what else was in the ointment in that particular time, but I wouldn't be afraid to try it, definitely. I don't know how you guys feel about that.
Same. Yeah, it's certainly low risk in trying it other than to your pocketbook because it is expensive. But to give it a try for a month or so and see if it helps, that's one of the many options.
Is there any sort of grade they should be looking for? Or again, there isn't a lot of science behind it, so you're not entirely sure what you're purchasing.
Some of these shops, my understanding is, they get audited and they're certified and their products are actually tested. How you discern which of those shops one is the other, I don't know. But I do know some are exposing their products to auditing to make sure what's in there is actually what's in there.
Okay. We have an email coming in. I don't have a name on this, but this person says, I'm a 69-year-old woman who has a very bad back. I've been getting back injections every 3 months for many years, which are helpful. I have spinal stenosis, arthritis, DDD, etc. I do walk every day, cross-country ski daily during the winter, and get plenty of, I'm thinking rest. It left me hanging there. But again, the injections, it doesn't say what type of injections. There are different types.
Sure. The most common that we see, and I'm not a spine surgeon, but the most common that you see really are the steroid injections, and it just depends on what they're treating, whether it's really the degenerative disc disease, whether it's arthritis in the spine, whether it's discs that are pushing on nerve roots, trying to calm down the inflammation, trying to do symptom control. It's like any of the injections we do in the body, none of them are going to necessarily reverse the disease process. You're trying to do symptom management with them.
Okay. The rest of the email says, what do you think of laser surgery? So that's where she was going with that question.
Okay. I'd love to jump in.
Oh, absolutely.
So Mary, you just described my average patient, actually, and mobilization, manipulation, lengthening, traction, learning how to move properly really helps. Really helps. Now, laser surgery is one of those sexy things that I talked about earlier. It can be helpful in really healthy spine patients with one area where there's a lesion, with one area of denigration. But when you have multiple levels of degenerative disc disease, DDD, and stenosis, laser therapy is really not indicated. And I say that based on what I've learned, and the laser center that we refer to as a chiropractic profession nationally just closed down for fraud and having bad outcomes. Now, am I throwing all laser under the bus? Absolutely not. But for multiple degenerative conditions, not a good choice. So rather, Mary, try an osteopath if you prefer, a chiropractor, somebody who makes sense. Open your spine up and you'd be surprised with all the other things you're doing. It could really make a difference.
Okay. We have Madeline here in Spokane. Hi, Madeline, and thank you for waiting.
Hi.
And you have a question?
Yes, I do. Recently, due to a fall, I had to have a hip pinned, which resulted in one leg being about an inch shorter than the other. Now, I've been through therapy, physical therapy, both occupational and whatever the other one was. I'm wondering, does that give me more of an alignment problem for the future? What can I do about that inch? Should I not be that concerned about it? What information can you give me?
Dr. Howie.
I think the big thing is how does it affect your movement? And as we've mentioned, that's in the end kind of what can contribute to other things, being overstressed. And so that'd be the big thing, be evaluated by someone who can actually watch you walk and watch the way that you move. And if it looks like, because of that discrepancy, that you are favoring it or it is making you walk inappropriately, then you could consider things like a lift, where one side is lifted up of your shoe, and there's a lot of different options, or even some manipulations to kind of help with some asymmetry, but a lot of things out there. But you want someone to watch you actually move, and then, because not all people with legs that are a little off need something.
Since most of us are a little off
Very much
anyway.
so.
But I'm interested in, you have to deal with that in trauma and trying to guesstimate a lot. How do you handle some asymmetries? What do you recommend?
We look, again, I definitely agree with it. Depends on how bad it's affecting you. And so there's quite a few different things you can do. I mean, one, we check our x-rays. Sometimes the hip, if you pinned it, so that can mean different things. But if screws were put in and the ball collapses down as it's healing, then you lose bone height. And then really the only way to try to improve upon that really is to modify. You can modify your shoes. You can get lifts inside the shoe. Typically, when you do get to an inch, a lift inside the shoe will not work. You're really going to need to go to a shoe cobbler, and they can actually put in a layer and give you that back. If the hip starts really bothering you, it starts getting diseased, that typically can be, that length can be made up at some point with a hip replacement if that was ever something that, again, if the hip became really symptomatic for her.
And I wanted to talk too, because we're coming toward the close of the show, but I want to make sure that we do talk about the new procedures that are available for hip replacement and knee replacement. They're not nearly as invasive as they used to be, and there are some new options.
There are. The parts have stayed the same. The way we get into the hip and into the knee we've got some more options. The approach that really is probably getting marketed quite a bit and is talked about a lot is the direct anterior hip replacement. And it's going through the front of the hip, and what we're doing is we're not typically cutting the muscle off the bone like we do with the side approach and the back approach. If you look at the pure anterior approach, if everything goes like you want, and you look at our functional outcome studies to see how are people really doing with this approach, at 6 weeks it beats the other approaches pretty well as far as function and walking and naturalizing the gait patterns go. When you get out to about 3 months, the other approaches start catching up, and all of them have advantages and disadvantages, but a less invasive approach is going through the front of the hip. The newest thing in the knee replacement world is really the Mako robot, and they're starting to use, it's not that the robot's doing all the surgery for you, but we get a CT scan ahead of time. We're able to actually map out the knee, the arthritis, the deformity. We actually plug that data into the robot, and then during surgery we take a bunch of data sets. Now when we take that robot in, we actually use it to help make our cuts. I've gotten certified on it. I've got 2 of my partners that actually do a lot of the robotic surgeries. I don't. But what they do is then you take those parts and you're supposed to have more of an ideal on where they're going to be placed. And so the hope is we put our parts in better, the knees are going to last longer. And right now, early studies are hinting that the robotic surgery, they're showing there is some slight increased survivability, but we do not have, I will caution people, we need 10-year and 15-year studies when it comes to joint replacements to see how well they hold up and perform versus kind of our standard. But it's exciting.
Yeah, no doubt. And I would guess recovery time may be a little bit better?
A little bit faster. When we've looked at our own data at Sacred Heart, the robotic surgery, actually, they have less, almost a day less in the hospital is what we've been seeing with some of the data we've run.
Wow, pretty amazing. Well, we are getting toward the close of the show, and I just want to take a few seconds for each of you to just leave us with some closing thoughts on bones and joints tonight. We're getting into Bloomsday training. Hoop Fest is coming up quickly, and some things to remember.
Well, especially with those activities coming up, get shoes now, break them in. You don't want to do it during Bloomsday, and get active now, not later. You can get stress fractures and other injuries, so just be cautious with that.
There you go, starting from the bottom and working our way up. Dr. Pearson.
I would just say, if you have pain, try to find a solution. And just because you don't think you can doesn't mean you can't. And just because someone said you can't because you're getting old doesn't mean you can't. Go to the basics, mobilize the body, mobilize the joints, lengthen the muscles, learn how to move, eat right. And then if that fails, we have everything else under the sun to fix you at next levels. And also, I beg people, don't believe that your pain is coming from your age.
All right.
And it's an option.
Quickly, Dr. Howie, some final thoughts?
I just encourage people to find creative ways to get active and to know that their body is created to kind of fix itself if we give it what it needs. And so don't forget about the basics of diet, of sleep, of water intake, exercise, all those things, because often the body can do its thing if we just give it what it needs in a little time.
All right. And finally, very quickly.
Pain should not be a limiter. I will encourage people, if they're hurting bad enough, it's not the wrong answer to get in and get some x-rays and talk to your doctor. Just because you have arthritis doesn't mean we need to do a joint replacement on you. And so sometimes having that knowledge will help you with therapy, will help you make modifications, and it'll just give you more information on your body.
All right. Very good. Thank you all so much for being here tonight and covering a very broad topic. And that's going to do it for this edition of Health Matters. Our thanks to everyone who called in or emailed questions. And if you're looking for more information on tonight's topic, you'll find some helpful links on our webpage located at ksps.org. And be sure to join us on April 18th when we get the answers to some common medical myths. Until then, I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the Friends of KSPS, and by Providence Healthcare.
I'm Arnie Peterson, and I'm an orthopedic surgeon, and I work at Sacred Heart for Providence Medical Group. When I needed my hip replaced, I chose Providence because of the professionalism and the care that I knew I'd receive. I never thought twice about going anywhere else.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?